title of my talk is Pulmonary Mechanics and Pulmonary Edema in the Management of RDS and BPD, to be or not to be. I wanted to give this talk sort of to give some insights into my clinical management style being new to the group. I like to say that if you pulled 10 neonatologists in a room, you're going to get 10 different ways to manage lung disease, but that's okay. That's the beauty of neonatology. After all, the only FDA-approved drug is surfactant. So everything we do is from our training, evidence-based from clinical trials or observational studies, and hopefully sometimes animal data, and sometimes drugs and practices that work in adults are directly applied to babies without animal studies or clinical trials. So generally, it is good to be flexible and open-minded, but at the same time, fairly cautious in not adopting any new style or holding on to a familiar practice. So today I want to talk about pulmonary mechanics and pulmonary edema in the management of RDS and BPD. So is this a myth or is it real? Or is it just something we study for board exams and don't need to apply to clinical care? So we'll find out. I don't have any conflicts to disclose. The objectives of the talk, first, to highlight the transition of fetal lung fluid from intrauterine to extrauterine life, eventually, and then review the mechanics of breathing including lung volumes, compliance, resistance, work of breathing, and time constant, and discuss the clinical application of pulmonary mechanics to the understanding of RDS and BPD, review a little bit of oxygen physiology, and then highlight some management strategies based on what we've talked about in RDS and BPD. So an understanding of the transition of the preterm infant to extrauterine life is critical in understanding pulmonary mechanics and the physiologic rationale behind managing lung disease in the preterm infant. So as we explore, we're going to explore the differences in the in utero and ex utero environment that affect the fetus and how it contributes to the abnormal adaptations in the newborn preterm infant. In utero, there is a low oxygen tension, and that sort of creates like a physiologic hypoxia with a PO2 as low as 20 to 35 millimeters of mercury. But in that low oxygen tension, proangiogenic growth factors are released, like EPO, vascular endothelial growth factor is the most critical one, and this drives normal vascularization and blood vessel formation simultaneously, not only in the lung, but as well in the other organs like your retina, your brain, your kidneys, and other fetal organs. So at birth, there's now suddenly an exposure of this newborn infant to a higher oxygen tension compared to the ex-uterine environment. The oxygen tension in room air that we're breathing is about 100 millimeters of mercury, and that is very hyperoxic for the newborn infant. And in high oxygen, vascular endothelial growth factor, VEGF, is downregulated, and that causes like an arrest or a halt of vascular development in the retina, lungs, and other organs. And we know that the lung develops progressively in a relatively hypoxic environment, and being born into a high oxygen tension environment or hyperoxic environment would affect the structure and function of the lung. And most of these babies that we're caring for prematurely are born at the lowest gestational ages of survival, 24 to 26. We've been seeing 22 and 23 weekers, more in the canalicular stage of development. So they do not have fully developed lungs, and that affects the adaptation to extrauterine life. Now, what happens in the retina? The retina is the inner layer of the eye. It's not a flat tissue. It is made up of 10 layers of a network of synapses, of neurons and glial cells, and these are maturing as the infant grows. So they need blood vessels to nourish them, to bring the oxygen and nutrients. And the retinal blood vessels start to develop at about 16 weeks gestation and do not reach the periphery till about 40 weeks or term. So you can imagine that a baby born at 24 or 22 weeks does not have retinal vessels all the way out in the periphery. and that gives you an avascular, I don't know if you can see my pointer here, an avascular peripheral zone. Now, 4 to 6 weeks later, as the infant is getting bigger, organs are growing, you now have a very hypoxic retina, because the retina is one of the most highly metabolically active tissues in the body and the brain. And these neurons are constantly, like the photoreceptors, shedding their outer and inner layer, and they're constantly multiplying. So they really need this oxygen right away. So when they don't get it, they get very hypoxic. And now you have excess secretion of vascular endothelial growth factor, and that causes abnormal vascularization. And these new vessels are fragile. They don't have a basement membrane supporting them, and they tend to bleed. And then you can have bleeding in the eye, and then you have proliferative ROP. So the first phase of ROP, when the vessels stop growing, is called vasoobliterative phase. And then 4 to 6 weeks later, you now have the proliferative phase. So this biphasic transition of vascular progression in ROP is really important in managing the newborn infant, especially the premature infant. So as the infant grows from fetal life to extrauterine life at term, when we have these babies at delivery, you want us also support that transition by allowing the conditions that they had in the womb. So in the womb, they had physiologic hypoxia because their PO2 is as low as 70%, and they were just developing fine. So when they're born, we need to have some sort of a permissive hypoxemia, so allow this normal vascular development to continue without being disrupted. And that we now know that we don't need the babies to sat 100% with supplemental oxygen. So we're now allowing a lower oxygen sat, so about 85, 88 to 92%. But then, because of the biphasic nature of ROP and also lung development, that changes from 4 to 6 weeks of life. We should be allowing a permissive normoxia. This baby should be having a better saturation, about more than 92 degrees, 92%. And this is also to limit the hypoxic stimuli coming from the retina that will be driving abnormal bleeding or vascular development from ROP. And this also coincides with the time when they're evolving BPD or PPHN, and having normal saturations that limits exposure to fluctuating hypoxia will be also helpful for the lung development and normal transition. So we see that there's a simultaneous development of both the lungs and the retina, that if it happens in a smooth way, the baby develops normally. And if it doesn't, you have abnormal and repair mechanisms that can lead to BPD and ROP. So just a quick recap of how these two organs and the rest are affected by simultaneous development of vasculature and structure. So let's talk a little bit about fetal lung fluid. In utero, the fetal lung fluid is filled, the lung is filled with fluid, and that is to maintain airway volume equivalent to functional residual capacity, which is about 20 to 30 milliliters per kilo. The fetal pulmonary epithelium secretes alveolar fluid, sometime about 6 weeks of gestation, and the chloride ions are located in the interstitium, and they're transported through the active transport through the sodium potassium 2 chloride transporter into the alveoli, and then they passively enter into the alveolar space through the chloride channels. So the epithelium in utero is predominantly a chloride secreting epithelium, and the volume of the fetal lung is maintained by the larynx, which acts like a one-way valve, allowing only outflow of fluid. Then what happens right prior to birth? A few changes happens. The pulmonary epithelium now changes to a sodium secretion. You now have postnatal fluid reabsorption that happens mediated by activation of the ENaC channels, the epithelial sodium channels, and this causes passive movement of sodium through these ENaC channels. And then sodium is now actively transported back to the interstitium through the sodium-potassium ATPase pump. And this creates an osmotic gradient that now allows chloride and water to follow. And then these get absorbed through the pulmonary circulation and the lymphatics. So Starling forces here and the thoracic squeeze are able to play a minor role in clearance. So how much of fetal lung fluid is actually cleared at birth? 35% is cleared prenatally. And this is days after, just before birth, you have a decreased formation and secretion of chloride. And then you now have the epithelial cells pumping sodium into the, from the alveolar space into the interstitium. There's an increase in oncotic pressure. And you know the fetal lung fluid is low in alveolar protein, but high in sodium and chloride and potassium. So there's an increase in lymphatic oncotic pressure, and the low fetal alveolar protein now leads movement of fluid from the alveoli out to the pulmonary lymphatics. Then 30% of the fetal lung fluid is next cleared during active labor. And this is through the mechanical forces of compression of the fetal chest as the baby is coming out through the vaginal canal. And at the same time, there's a catecholamine surge that happens with maternal secretion of epinephrine. Cortisol is also secreted in higher amounts, and thyroid hormone concentrations increase. And these all aid and facilitate transepithelial sodium movement. And then 35% of the remaining fetal lung fluid is driven out postnatally. And that just comes from increased lymphatic oncotic pressure again. And when the baby starts crying, there's an increase in thoracic pressure, and that keeps the alveoli open and forcing fluid into the adjacent capillaries and lymphatics. So you can't imagine that a baby that's born by C-section that did not have normal labor days prior, for some reason, maybe it was preeclampsia, that did not get a vaginal birth because it was C-section, now has retained fluid in the lungs that did not clear prior to this. And the baby didn't get to cry because of surfactant deficiency, and then not having enough pulmonary, having some respiratory insufficiency, and now gets intubated. So you can have as high as 80 to 90% of the fetal lung fluid still retained in the lung at birth. And that is really important as we transition in the first week of life to allow that physiologic contraction of extracellular fluid, and most of that is going to come from the lungs. So at birth, what the baby needs to do, it seems like it's an easy thing to do, but it's really, really hard, because in that first minute, they need to force all the fetal lung fluid out and fill the lungs with air and establish functional residual capacity, or FRC, in order to have effective gas exchange. So that leads us to the mechanism of breathing. So how does, let's take a closer look at how the lung works. I like to look at the lung as being elastic like a balloon. When you increase pressure, it can inflate. When also you deflate it or decrease pressure, or the volume is low, it can deflate like an elastic balloon. At the same time, if you give too much pressure, then you can pop a balloon, the same thing as the elasticity of the lung. If there's too much pressure or volume in the lung, it can cause rupture of alveoli. So that's very important to keep in mind. So let's talk about lung volume. So the first breath that's initiated when the baby is born is usually the largest breath we should consciously give, because you're trying to push all the fluid out of those fragile lungs, and you're trying to push in enough pressure to generate volume and replace and maintain FRC and start tidal breathing. So sometimes you may need to use as high as 45 millimeters of mercury, and that really should be one of the highest pressures we use. After that, the next pressure should be gentler and gentler. Go as low as you can, 18 or 20, to maintain tidal breathing and maintain your O2 sats in the expected range of 85 to 92%. So the goal of the first breath, I said, is to establish FRC. FRC is about 20 to 30% ml per kilo. And then tidal breathing, like we know, is about 5 to 7 cc's per kilo. You don't want to breathe at total lung capacity, which is anywhere from 50 to 60 ml per kilo. So the static pressure volume curves talk about the relationship between the different forces that affect lung expansion at different levels. Both the lung and chest compliance together give you the total respiratory compliance. And when they're in equilibrium, this is at FRC, or functional residual capacity. So to generate airflow, atmospheric pressure has to be higher. So the transpulmonary pressure is a difference between the alveolar pressure and the interpleural pressure in the pleural cavity. And so once that drops to negative pressure, about 5 to 8 centimeters of water, you generate airflow and get your lung volumes. So once you generate airflow with breathing, what we want to do is use as much pressure for that initial breath. And in the baby that has RDS, that may take a lot of pressure. And what you want to do is do that when you generate pressure is to allow volume to come into the lung, and you have your inspiration, and expiration should be passive. You want to be able to do this at a safe zone, which is at this steep part of the dynamic compliance curve, and not at the lower zones where there could be atelectasis, and not at the upper zones where you have overdistension. So dynamic compliance literally measures how elastic or distensible the respiratory system is a change in volume for a given change in pressure. It reflects the elasticity of the lung, and it's measured in normal, regular breathing. Some things that can reduce compliance would be increase in pulmonary venous pressure when you have an engorged lung, alveolar edema. If you have atelectasis, that would decrease your compliance. And also, at the same time, fibrosis over distension of the lung in restrictive lung disease can also cause it. So FRC generally is defined as the volume of air remaining in the lung after normal expiration. And a residual volume is the volume of air remaining after forced expiration. You are not able to calculate residual volume. So FRC, if you subtract that from your expiratory reserve volume, that's how you get your residual volume. So FRC is really the equilibrium where lung elastic recoil matches the chest wall expansion. So in your dynamic volume pressure curves, at low FRC, we talked about you're gonna have low lung volumes, and most of your RDS babies will be sitting around here. You wanna ventilate them or give them supplemental oxygen to open up their lungs and drive them higher up this compliance curve, because here they have low compliance. So you wanna get to the steep part of the curve. So here you're seeing that a lot of pressure is needed before you generate any volume here. But at the same time, this curve looks flat. But over here, very little pressure is needed to generate volume. And then you have a generous amount of volume here. If you keep increasing your pressures of volume, whatever mode you're using, you're gonna get to the steep, higher part of the curve where it's a sigmoidal curve, it flattens. So any more pressure at total lung capacity does not generate any more volume, because the baby is limited by the rib cage and the chest wall, and your lungs are you only have 12 ribs. So, and then the diaphragm also limits the amount of lung space that is used for gas exchange. So if you keep the baby at total lung capacity, you're gonna have high FRC established in the lungs, and the compliance is gonna be very poor and low, and the baby is gonna be at risk for air leak. So how the compliance is always best at FRC. So how do the infants maintain FRC? When they're retracting, they're trying to maintain their expiratory muscle activity throughout expiration. And if they're grunting, they're trying to increase expiratory resistance through laryngeal abduction. And sometimes they're tachypnic, and that's really just breathing at very high frequency, trying to limit the expiratory time. So this is just some clinical application of the x-rays to the compliant curve. We talked about RDS. There's low lung volumes happening here. The baby's lungs are very non-compliant. They're very poor due to atelectasis. To manage this baby, you want to use shorter I times, because it's a very homogeneous lung parenchyma in RDS. So it doesn't take a lot of time to for airway equilibration. You want to use lower pressures at the same time and faster rates. So generally, for you to be at normal FRC, you need to have normal lung expansion, which is anywhere from 8.5 to 9.5 ribs. If you have less than 8 ribs, you add low FRC. So you want to be able to ventilate the baby and get them to normal FRC. If you keep going with your pressures and volume, you're going to drive a higher FRC in this baby. You can see you encounter some resistance here because we are limited by total lung capacity. There's nowhere else to go beyond the 12 ribs. So the diaphragm is pushed down. That's now decreased the compliance because the baby is breathing at high FRC. And this clinically we see in BPD babies, babies that have meconium aspiration. They have a very heterogeneous lung parenchyma. Some areas have atelectasis, some areas have fluid alveoli, and some areas are overexpanded with air. So you need longer time constants to overcome the increased resistance and allow enough time for airway equilibration in this very heterogeneous airways. And then in ventilating, you typically use longer I times and lower rates. So what's important to note here is if you have babies showing increased pulmonary vascular resistance and echo evidence of PPHN, you want to check your lung expansion because if you have over distension, you're going to be compressing on those capillaries around the alveoli, and that could increase your PVR. So it's important to make sure your lung expansion is adequate before starting nitric or evaluating for nitric. So resistance is basically the friction between the lung and chest wall. If it's viscous resistance, there are two types of resistance. And the airway resistance is the frictional forces that occur within the gas molecules and the airway. And that is affected by the flow velocity, whether it's laminar or turbulent, as well as the dimensions of the airway and the gas viscosity. So Poiseuille's law talks about the relationship between airway resistance and the diameter of the airway. It shows that airway resistance is inversely proportional to the radius to the fourth power. This would mean that in larger airways, you have less resistance, and in smaller airways, you have lower resistance. But that doesn't always hold true physiologically for the baby because the tracheobronchial tree has dichotomous branching, and they're very narrow. As they get smaller. So individually, the smaller airways would have a higher resistance than the larger airways. But because of the downstream branching that happens, it reduces the total resistance because all these tiny airways are in parallel, and their total resistance is now less. So that tells you that airway resistance is increased at low lung volumes and decreased at higher lung volumes. So let's talk about work of breathing. Work of breathing is looked at as the force times the distance is the product of force and the displacement. It's the expenditure of energy that is developed by the respiratory muscles to overcome elastic and resistive forces required to move gas in and out during spontaneous respiration. The dynamic compliance curve tells us the work of breathing that's needed. If you look at your A, B, C, and A, that represents inspiratory work, the work, elastic work that needs to be overcome for inspiration. And then your A, C, and D represents expiratory work, which is due to airway resistance or frictional resistance. Then you have the total work of breathing A, B, C, E, A, and that is like how much energy is expended in a single breath to be able to move air in and out of lungs. The concept of time constant is important. Time constant tells you how quickly the lungs can inflate and deflate. And mathematically is the product of airway resistance and lung compliance. In a healthy lung, the time constant is about 0.9 to 0.15 seconds. Sorry, having this go quickly. And it takes about one time constant for alveoli to discharge 63% of the airway volume out of the mouth. It takes two time constant for 84% of alveolar volume to be discharged, and about three time constants for 95% of alveolar volume to be discharged. So looking at this graph here, If this is an alveoli that has normal compliance and normal resistance, this will be the time constant about 0.5. This is, I think, closer to adult values. But in this other alveoli, you have a decreased compliance. You can see the number is half. So at the same amount of resistance, your time constant is shorter. But in this other alveoli, you have increased resistance. You can see their value for resistance doubles. And because of that, you have a longer time constant. So this is just a table showing you the normal units for tidal volume, and know that your volume is decreasing RDS compared to normal, and sometimes decrease in BPD, but they can also be higher. Your FRC is about 25 to 30 ml per kilo, a little bit lower for the RDS baby and BPD baby due to poor compliance from a heterogeneous overdistension. And then compliance is much decreased in RDS compared to normal babies, and a little bit variable in BPD on the lower side as well. The resistance is normal here at 25 to 50 for a normal infant, but for an RDS, it can be increased just because of the frictional forces related to fluid retention in the lungs. And it can have much higher resistance in BPD. And this translates to the time constants we talked about, lower in RDS and much longer in BPD. So a little bit about the concept of pulmonary edema. There's a concurrent development of airways and vasculature. We've talked about that. And in the embryonic stage of lung development, the lungs buds appear first as an output protrusion of the esophagus and penetrates and divides into the surrounding mesenchyme. And then they start to have dichotomous branching. By the pseudoglandular phase of 5 to 17 weeks, you now have your neuroepithelial cells being developed, your goblet cells. And at this stage, the branching can be about 15 to 20 times. By the canalicular stage of development, 16 to 25 weeks, your pulmonary acini start to develop, and you now form a blood-air barrier with surfactant production by 20 weeks. And they have increasing amount of capillaries in the mesenchyme. And then it starts to thin and sort of merge with the respiratory epithelium. And by saccular stage, where a lot of the babies are born, you now have a more alveolar ducts forming, and then the actual alveolar sacs start to develop at alveolar stage. So you can imagine that any preterm birth here would have incompletely developed alveoli or number. A newborn baby that's healthy would have about 50 to 100 million alveoli. So a preterm baby would have, a little bit less than that. So it takes us to RDS. This is just a clinical presentation of RDS. These babies have surfactant deficiency. They're retracting, they're grunting clinically. They have hypoxemia due to intrapulmonary shunting. They may have a PDA that could be clinically silent or significant. And histologically, we're looking at diffuse atelectasis in this histology. The top one is normal lungs. You can see normal alveolar spaces. But here you have diffuse atelectasis. The alveolar spaces are sort of flattened and not very open. And now you have these hyaline membranes, which are just proteinaceous exudates and fibrin that are filled in the air spaces and around it. So this is not conducive at all for gas exchange. And the arrows here pointing to your air bronchograms, and that's really just showing a contrast between the air in the bronchi and the surrounding atelectatic alveoli. In clinically in RDS, you can see whiteout lungs where you sort of lose your hard border, and generally the lung volumes are low, sometimes under 8 ribs or just about 8 ribs. And you can have some cardiomegaly, but you also want to rule out birth asphyxia or in case of IDMs. So for surfactant is important. The benefits of surfactant in RDS babies, it reduces the critical opening pressure. So you don't have to use that much pressure to open up the lungs and generate inspiration and expiration. It improves the compliance of the lungs, so the dynamic curve, is not going to be as flat as in RDS, but without surfactant. And it stabilizes the alveoli such that the smaller alveoli don't collapse at the end of expiration. It keeps the alveoli dry because there's surface tension. The collapsed alveoli tend to suck fluid into the alveolar space from the capillaries. Laplace law is a physiology that sort of describes what happens to surface tension, and we can apply that to alveolus. So you can see two alveoli of different sizes here. So Laplace law states that the pressure needed to keep an alveoli open would be equal to 2 times the surface tension and inversely related to proportional to the radius of the alveoli. So that means that for smaller alveoli, if you use the same pressure, these ones will collapse because it needs more pressure to open, and they will empty into the larger alveoli. So this also kind of tells us, assuming this is a bubble, this big bubble has a radius of 2 and the smaller bubble has a radius of 1. The surface tension is about the same. You can see you're going to need a lot more pressure by this calculation to keep the big bubble open. But what surfactant does is it reduces the surface tension and equalizes both the small and large alveoli. It's packed really tightly in alveoli that are small, and it spreads thinly in alveoli that are bigger. So you can do that with the same pressure. A quick concept about BPD. Back in the 60s, babies with RDS did not survive. And if they did, when they started having the advent of mechanical ventilation, then we now found a new chronic lung disease that was described by Northway about 1967, where these babies had received prolonged ventilation, high peak pressures in vents, and these babies were a little bigger, about 34 weeks, at a mean weight about 2.4 kilos. But by 28 days of life, they noticed that they had progressive chronic lung disease changes in their x-rays, and pathology showed infiltration with inflammatory cells, alternating areas of overaeration and atelectases, and the lung parenchyma that sometimes looked fibrosed. But with advent of advanced neonatal care with surfactant and gentler practices, we're now seeing babies that are born at much smaller gestational ages, and a new form called the new BPD has evolved. You can see alveolar simplification because they are born at the canalicle and sacral stage, and had lung arrest in development before alveolarization was complete. So these lungs have fewer alveoli than normal lung and a little bit dysmorphic, but they don't seem to have the same chronic character as the old DPD. They could sometimes be overinflated following surfactant administration. So there's been an evolution in the definition of BPD for time. I'm going to just skip through this. It went from requiring oxygen at 28 days to needing supplemental at 36 weeks by the 70s. And then by the 90s, we were defining it based on mechanical ventilation and clinically grading them based on how much FiO2 they were needing. So the NICHD 2000 definition looks at them at mild, moderate, or severe BPD. If they've needed oxygen for more than 28 days, they're clinically tested at 36 weeks. So we can see that the pathogenesis of BPD is multifactorial. It can start from antenatal factors that are affecting the baby. Babies with choreo have increased risk of BPD. We've talked about persistent fetal lung fluid being a big factor. And all these are causing injury to the fetal lung, which is growing in hypoxia, already filled fluid lungs, and with retinal that's been vascularized. Then the baby is born and exposed to high oxygen environment. Now, I'm going to talk about a little bit about the free radicals. So oxygen is a very reactive drug. It's actually a very powerful drug. It's important for maintaining the lung volume and respiration and all cellular respiration in the body. But the amount of oxygen given has to balance with the existence of endogenous antioxidant activity. And in premature infants, there's insufficient antioxidant activity. So this imbalance drives free radical development and reactive oxygen species being formed. And these can cause direct damage to the lungs and alveoli epithelium and cause injury. So oxygen causes injury in the way that it attacks the alveoli, and the body feels like there's need to repair this injury and starts attracting inflammatory cells, protein, and water into the alveoli, sort of propagating the same inflammation. Other postnatal factors are ventilation, using high pressures and volumes to ventilate the baby. We've talked about retained lung fluid, and as the baby gets older, this progresses into pulmonary edema, and we'll talk about that a little bit later. Infection and cytokine production are also big factors that affect the baby postnatally. So all these are happening to this premature lung that has arrested alveolarization and vascular development, and coupled with ongoing inflammation from oxygen, over distension of the lungs from ventilation, possibly infection. So if you are able to have normal repair and growth of these lungs, you could still have normal lung. But any continuation of this injury past a few weeks will lead to BPD. So what happens in alveolar gas exchange? Do you know that atmospheric oxygen is a mixture of gases? Like Dalton's law of partial pressure tells us that the partial pressures of non-reactive gases, the total pressure they exert, is equal to some of the partial pressures of the individual gases. So oxygen actually flows down a pressure gradient from the atmosphere to the alveoli. And the expected partial pressure of oxygen in the alveoli is calculated by the alveolar gas equation, as we can see here. So, and then you can see your pulmonary arteries carrying your deoxygenated blood, and the gradient of higher CO2 drives that into the alveolar airspace. And then oxygen-rich gas is coming from the atmosphere, and that higher gradient of pressure of oxygen, partial pressure of oxygen, it's a little bit diluted by water pressure as it comes into the lungs. And when it gets to alveoli, it's about a PO2 of 100. And that higher gradient than the those in the pulmonary veins drives oxygen into the pulmonary capillaries. And then here are the capillaries. Then you have your pulmonary veins carrying the oxygen bound in the hemoglobin to the tissues. So here in our alveolar gas equation, it tells you the partial pressure of oxygen at any given time in the alveola. It's important to note the respiratory quotient here. I think this is important when we feed our babies, knowing that certain nutrition macromolecules will give you a higher respiratory quotient. Your fats and your carbohydrates will give you a higher respiratory quotient that would convert it to more CO2 and water compared to proteins. So it's important to have the right amount of both fats and nutrients and proteins when doing your calorie calculations. There are other factors that affect diffusion of gas in the alveolar capillary membrane. Is affected by surface area, and surface area can be reduced by atelectasis or immature lung or the new BPD. It's affected by pressure gradient. We talked about the pressure gradient that drives oxygen to the alveoli and CO2 out of the alveoli. Another thing that's important is the diffusion distance. Diffusion distance in gas exchange can be increased by interstitial edema in a premature lung, and it can be increased by pneumonia and pulmonary edema, that they thicken the membrane, so there's a longer distance for diffusion. So this is what a normal lung would look like on this side. The normal alveola, you have your air-filled lung alveolar sac. You have your capillary basement membrane lining. But then when the lung is injured, you have an activation of white cells, your neutrophils. You have a sloughing off of the bronchial epithelium. You have activation of the macrophages who try to engulf this cellular debris. You have fibrin deposits starting, and then you have extravasation of fluid into the alveolar space. And oxygen wants a clear, thin membrane only between the alveolar sac and the capillaries. So in an injury, either caused from oxidative stress, from infection, or from directly from the mechanical ventilation, you now have this increased diffusion distance, so that when you use your FiO2, your baby is still desat, and you now have to increase FiO2 to push the gradient through this distance. So it's important to note that edema between the alveolar sac and the capillaries can affect a lot of the mechanisms of pulmonary gas exchange, and bear that in mind. So if you're not achieving or you're needing high FiO2s above 50%, look at a way to control either conservative fluid management or a gentle diuresis with some modality, either chronic diuretics or LACI if the baby is older. But at the first week of life, we'll talk about that later, that's when Starling forces are working. The fluid that's retained in the alveolar sacs are still low protein. There are no inflammatory cells in it, so they can shift easily. But if you wait 2 to 3 weeks and there's still retained lung fluid with ongoing damage and inflammation from mechanical ventilation and high oxygen use, then you have an alveolar sac that's filled with debris, that's filled with inflammatory cells, and then the Starling forces are harder to shift fluid out. That's also complicates clinical care. And a repaired alveoli would try to get back the integrity, but you still have some collagen deposition and some fibroblast proliferation after injuries. So that takes us to a little discussion about minute ventilation at dead space. It's important to note that alveolar minute ventilation is a product of your tidal volume and dead space. Sometimes when the baby is breathing fast, you want to think, is it that they're trying to maintain the same minute ventilation because their tidal volume is low? So it's important also in these chronic babies to check their x-rays. They may be on high flow for a few weeks, but if they continue to be tachypnic, you want to make sure that they have the adequate tidal volume. That could be the reason that they're breathing fast or being very tachypnic. And when you're delivering tidal volume, especially through ventilation, you want to note the dead space that can come from either the ET tube length, that's why they're better when they're shorter, the size, the flow sensor, and then we have the physiologic dead space that can also affect gas exchange. This little schematic here tells you that for every tidal volume breath that you push in, you have some air left in the conducting airways that are in the anatomical dead space that are not involved in gas exchange. So you have a new breath that's coming in and you push it in. What's going to happen is the air that was previously in the conducting airways that are not involved in gas exchange are pushed further in. So you're actually not delivering, in this case, 500 ml. You're actually just going to be delivering 350 ml in your tidal volume, because 150 has to be still left in the conducting airways. So it's important to note that when you set your tidal volume for your vents at 5 to 7 per kilo, you may need to increase it to make allowance for a physiologic dead space. So it's a few points about oxygen physiology. Oxygen, like I said, is an irritant. When it gets into the alveoli and gets diffuses into the blood, it binds to hemoglobin, and hemoglobin has a quaternary structure that has 4 binding sites for oxygen. Hemoglobin has huge affinity, high affinity for oxygen, and oxygen content, it's important to know that it's determined by the oxygen bound to hemoglobin, which is 95% of it, versus oxygen that is dissolved in blood. So for oxygen, this is the equation, the factor of 1.36 times hemoglobin times the O2 sat. So you can see the factor is higher for hemoglobin in this side of the equation, which is the oxygen bound to hemoglobin, as opposed to this side of the equation, which is oxygen dissolved in blood, that has a very small correction factor of 0.0031. So in a scenario like this, where you have a baby with a hemoglobin of 9, O2 sat of 99%, and PO2 of 80, which would be the one with a high oxygen content? If the baby B had a hemoglobin of 12 that was higher, but O2 sat that was lower, and a PO2 of 50. So we can see from that equation that actually the baby with the lower hemoglobin, even though sat at 99%, is more hypoxemic because of a lower oxygen content, because you don't have enough trucks carrying oxygen. So let's talk about oxygen delivery. Oxygen delivery is important because that determines oxygen available for consumption at the tissues, and that equation is cardiac output times the oxygen content. We've talked about oxygen content. The cardiac output is your heart rate times the stroke volume, and the stroke volume is affected by preload, inotropy, and afterload. So in relation to pulmonary mechanics, when your baby is overexpanded, more than 10 ribs at a higher part of the compliance curve, breathing high FRC, you're going to have a distension of the lung such that the heart is compressed and prevented from filling. So most of that time, you're going to have a baby that has decreased preload, and you're going to have a baby that initially would increase the heart rate, trying to maintain the same cardiac output. And that will be impeding venous return. But if you continue in that situation, sometimes these babies will now progress to bradycardia. So it's important when you check x-rays to ensure that if the baby's compliance improves, let's say after surfactant or after vent change in a BPD baby, and you get to 10 or 11 ribs, to still try to reduce that the pressures or volume that you're using to get back to the steep part of the compliance curve. So this talks about hemoglobin affinity for oxygen, and this is important generally in care of the babies. There's a high affinity for hemoglobin for oxygen, and we want to make sure that there are things that drive this curve, oxygen dissociation curve, to the left or to the right. If it's shifted to the left, this is in the conditions of alkalosis, where your pH is high, the PCO2 is low, and you have low 2,3 DPG. So this causes hemoglobin to bind tightly to oxygen and won't release it to the tissues. So it's important, that's where you have your permissive hypercapnia, to let this hemoglobin, after it's transporting this oxygen bound, so when it gets to the tissues, to be able to release it to the tissues, you need to allow acidosis. Sorry, it's an error. You need to allow acidosis, which would be a lower pH and high CO2s, and 2,3 DPG, which allows more release of oxygen to the tissues by binding to hemoglobin in place of oxygen. And also we can see the P50 here is a partial pressure at which the baby sats are 50% O2 sats. This is a sigmoidal curve that flattens here. So it's important to note that 100% sats, this curve flattens so that you do not know, if you're giving supplemental oxygen, how much oxygen you're given, what exactly your PO2 is, especially if you don't have arterial gases. So if you're following regular cap gases and the baby sat at 100% on mechanical ventilation, you may also pay attention that your PO2 at 100% sat could be anywhere from 100 to 300, 400, 500. You don't know, because this curve flattens. So it's important when using supplemental oxygen to avoid staying at 100%. The babies needing maximum ventilation, sometimes they require that, but staying at 98% prevents this phenomenon of a hyperoxia, where you now have increased reactive oxygen species being produced. So real quickly, we still don't know how much oxygen is too much, but the primary goal of oxygen therapy is to provide adequate oxygen to the tissues without toxicity to the eye, brain, or other organs. So whether you use the mode to use this as a ventilator or oxyhood or a neopuff, the goal is to restore gas exchange and reduce work of breathing by assisting the respiratory muscles through ventilation and oxygenation. And you want to ventilate with the least amount of pressure. that will generate optimal volume at FRC. We want to oxygenate to enable cellular respiration and CO2 elimination with the least amount of oxygen that you need, because oxygen is truly a drug. So this little chart I made here sort of explains the relationship between oxygenation and ventilation and how they are related, interact with each other. The goal of using any of these in any modality is to avoid oxygen toxicity, avoid barotrauma, avoid volutrauma or eclectotrauma, which is constant opening and reopening of the alveoli, which can cause damage to the epithelium. Ventilation drives away CO2, and that is affected by a minute ventilation. We said that's tidal volume times your respiratory rate. And your rate can be changed by decreasing your expiratory time and changing your IE ratio. And your tidal volume is affected by a time constant, which is affected by resistance and compliance. We talked about oxygenation. The big driver is the mean air pressure. To increase your mean air pressure for oxygenation, you first increase your FiO2, but when you get to like 50, 60%, then you start working on increasing other vent settings to limit the toxic effects of oxygen, high oxygen. For mean air pressure, you can change your flow, your pressure gradient, which is your peak pressure, change difference between your peak pressure and your PEEP. And you can see how they're all connected. The IE ratio can also affect your mean air pressure. Your pressure gradient also can influence the tidal volume. Your peak pressure can change your compliance. And this is just the mean air pressure curve, area under the curve. Tells us like if you want to make changes on the vet, things we'll look at. You can, this is your PEEP, your PIPs, your peak pressure, and your delta P is the change in pressure. To increase area under the curve, you can either increase your PEEP, increase your PIP, or your I time, and you can also increase your rate, which gives you another bar and shortens the expiratory time. You can also increase the delta P, and sometimes you can do that by decreasing the PEEP or keeping the PEEP the same and increasing your PIP. So whatever you do, the goal is to change the mean air pressure. So if you have a baby that is overventilated at a mean air pressure, you check what it is. If it's 10 or 11, then your goal when you make vent changes is to make sure that mean air pressure drops by 1. You can go in small steps. If you haven't changed the mean air pressure, then you have not affected any change on that compliance curve. And then flow also will give you like a square wave. Increase in flow also increase area under the curve. So I'm going to end the talk with looking at fluids, calories, and oxygen, and how we manage that in BPD and RDS. So real quickly, is there a critical window? So the goal of fluid management is to really balance caloric intake with fluid requirement. And if you have too much fluid, you're going to have, and not enough calories, you're going to have fluid overload. So pulmonary tissue edema complicates BPD by reducing lung compliance and increasing airway resistance. And fluid volume or burden of the lungs has a lot to do with it. So let's look at the body composition of fluid with age. A total body weight is made up of solids and water, but water is made up of intracellular fluid compartment and extracellular fluid compartment. And the ECF, we have 80% interstitial and 20% plasma. So it's important to note that at birth, there has to be a reduction in the extracellular fluid as part of adaptation to cardiorespiratory function that is physiologic. So we need babies are born with excess water. We've talked about that with a fetal lung fluid and a high total body water and high total body sodium. So it's important to allow in the first week of life that reduce in weight, that reduction in weight, which is followed by diuresis and followed by contraction and increasing your serum sodium. And that is physiologic because as you can see, these are just meta-analysis of different studies showing that the lower the gestational age, the higher total body water that baby is born with. So your 24, 26 weeker can be born with as high as 90% total body water. So because of inefficient respirations from surfactant deficiency or from having a C-section and didn't labor, you now have this 90% total body water most of it being like 80% in extracellular fluid volume still remaining. And you can see how physiologic it is, because this is a graph showing that as the fetus transitions to newborn life, the total body water should decrease. And at the same time, the extracellular fluid volume should decrease. And this is accompanied by increase in extracellular fluid volume. So this is physiologic. So this should happen naturally. So when we don't allow the natural weight loss, then it affects the amount of extracellular fluid contraction, and that can cause retained lung fluid, which over time now becomes pulmonary edema and now becomes harder to shift because it now is now filled with cells and debris and fibrin, and that's just from ongoing inflammation, from ventilation, over distension, and oxygen toxicity. So this is another graph sort of showing us the natural history of total body water decreasing with age. And as the baby gets older, the extracellular fluid contracts, and the ICF should at the same time increase, only after gradually, but only after the first week, because then you want expansion of the cells and adequate sodium content in them for the cells and other tissues to grow. This graph is from a study from Michigan State University. It's an older study from the 90s, but I like it a lot because it shows a cohort of 32 infants less than 1,000 grams. And what it did was monitor the electrolytes and fluid early in life. They showed that the preterm infants undergo 3 phases of fluid and electrolytes homeostasis: a pre-diuretic phase, a diuretic phase, and a post-diuretic phase. And that has influenced a lot of clinical care over the past decades. So in the pre-diuretic phase, urine output in this study averaged about 1.6 ml per kilo per hour. There was increase in urine sodium excretion, and the GFR increased as well. And there was increase in the slight increase in the fractional excretion of sodium. By the diuretic phase, you now have more increase in your urine output. It almost tripled to about an average of 5 cc's per kilo per hour. The fractional excretion of sodium increased as well. And then in the post-diuretic phase, you now have the fluid intake is increasing in the baby. You now have less robust urine output in these babies. This other graph shows your urinary sodium. There's a net loss of urinary sodium due to increased fractional excretion of sodium. Your intake of sodium should be very low. So sometimes if your baby hasn't lost weight and they're fluid heavy, you would expect that the sodium would be lower in the 130s range. So if you're struggling with that and your sodium is still high in the 150s, you want to look at extraneous sources of sodium. You want to look at your fluids running in your lines, your UAC and UVC. If they have sodium acetate, you want to consider switching those out to either D5 water or D10 water, just to reduce the burden of sodium in the first week of life that would affect this physiologic transition, because you're supposed to have net urinary sodium loss. And at the same time, you should see an increase in your serum sodium. From my experience, I've seen these babies go up to like 147 and tolerate it very well. At the same time, you want to balance it with the fluids and adjust your fluids needs daily based on your weight loss, expecting a weight loss about 2% a day, and looking at your natriuresis and how high your serum sodium is rising. So to wrap up, generally the clinical management of BPD is multifactorial. There's no one way to do it, and it's not one size fit all. What you apply to one baby may not work exactly with the next baby, but what should be the guiding principle is the pulmonary mechanics. The lung works the same way every single time. The mechanics in the lung, the physiology of the lung is reproducible, is repeatable, and it does the same thing you expect it to do. So regardless of the baby's disease state, regardless of the mode of ventilation, if you follow the guidance provided by Pulmonary Mechanics, you will be able to ventilate your babies at a safe range and allow normal transition from extrauterine life, and then enable more effective use of calories. So they're used for growth and not used to overcome the resistance and the work being generated by the ventilators or high respiratory quotient from excess calories. So you want to optimize ventilation first, establish FRC at birth, make it gentle after that, use surfactant if you need it. Know that it can be inactivated by things like meconium and high oxygen tension. If you're using hyperoxia, baby may need more surfactant later on. Allow hypercapnia, so permissive, so you can shift that oxygen dissociation curve to the right and release oxygen to the tissues. Enable optimization of oxygenation, monitoring your SATs to adjust FiO2. Try to limit FiO2 once you get to a range of 50s, 60s, working on mean pressure and long expansion to limit FiO2 use. And if you need to use high FiO2s, avoid staying at 100% because that causes the most damage. Reactive oxygen species can increase PVR and worsen PPHN in babies that either have CDH or have BPD. It can cause direct damage to the alveolar epithelium, cause more edema, and complicate care for these babies. And then fluid management should be conservative. Like we said, allow physiologic contraction of ECF. And this can be augmented and helped by limiting transepidermal water loss, have your humidity high enough the first week. 90%, 80% should be fine the first week. And enable early nutrition. Babies that are fed early, especially protein nutrition, do much better and have the macromolecules needed for long growth. And then strike a good balance between fluid and calories. The calories shouldn't be all water. Fluid doesn't translate to better growth. If you don't allow the ACF contraction the first week, then your baby's fluid heavy, and then whatever calories you're giving in excess is not going to grow, is going to metabolize in oxygen, is going to overcoming the work from the ventilator. Early protein intake is important, and avoid excess calories because it increases respiratory quotient. Most babies do well with 24 to 26 calories per ounce. Pulmonary edema we talked about. This is implicated and made worse by oxygen toxicity. We limit use of diuretics in the first 2 weeks of life because of renal injury. But in BPD babies that are already fluid overloaded and did not take advantage of that contraction in the first couple weeks of life, then they need diuretics and judicious use of it. Use it to improve lung compliance and stop because of the effects on electrolytes. And then you're chasing water because you're now replacing with sodium after electrolyte losses, and then sodium brings back water into the lungs. So it's important to be judicious with fluid management in a conservative way and diuretic use in order to limit inflammation. There are different adjuncts that have been used for BPD, and you can find several studies either for them or against them. Steroids, bronchodilators, caffeine. Caffeine, generally, you have the Captra is been shown to be good for neurodevelopmental outcomes. Bronchodilators work in some babies, don't work in other babies. When you're using them, though, you need to remember that they add to your dead space. So you may not be directly delivering all the tidal volume you want. If you're in bronchodilators, you may need to increase your tidal volume for that baby. So this is just I think I'll stop here and see if there are any questions. Regarding fluids, it's a balance. There's no one size fit all. So here, the practice here is similar to what I start at, 80 to 90 per kilo for bigger babies, but generally 80 per kilo for preemie babies. And then what you want to do is, again, tailor it to the management of physiologic contraction versus sodium losses and urine output. Generally, you want 2% weight loss per day. about 2% weight loss per day. And you've talked about being not able to weigh the babies, but if you're following your sodium and your urine output, you can see that. You want to see urine output start to increase. So if there's not a robust urine output the first 24 hours, is expected, is physiologic, is the pre-diuretic phase, not to react to that with a robust increase in fluids, and be patient and allow that physiologic contraction to happen. And if you have the expected urine output, then you can stay where you are in the fluid. It's doing what it's supposed to do. And if you don't have a robust urine output, you may need to cut back a little bit on your fluids. And if you're fluid overloaded and you're gaining weight, and you're not having that increased diuresis that you should have by second, third day, then you probably need to cut back on your fluid. And if there's too brisk of a diuresis, then you can go up a little bit at a time, 10 to 20 per kilo at a time. So it's a balance. You just sort of have to weigh and not react to the sodium. I also see that, yeah, generally most NICUs, total fluids does not usually include your carrier fluids, your flushes, and your meds that also come with fluids, but that should really be included in your total fluids, or pay attention to where the fluids are coming from, on maybe drips and things that were not accounted for. So it looks like everybody's on the same protocol based on gestational age, but actually the babies that are sicker, that are prone to BPD, are receiving more infusions for like dopamine and meds and sedation, and from the lines, UV and UVCs. So generally, like when I assess like the next day, over like the fluid status of the baby, if there have been flushes, I count it in my total fluids. I find out how much is coming. If the baby's on 2 or 3 meds, I find out how much per kilo that accounts for, and just sort of account for a little bit. Maybe not match it 1-to-1, but pay attention to that when you're calculating your total fluids. And maybe you don't need to increase by 20 that day if the baby didn't lose weight, or if the baby hasn't diuresed enough, maybe you can go by 10 or stay where you are and force that contraction. Because what's going to happen, the baby is going to maintain blood volume by pulling out of the lungs into the vascular space. You see that these babies in the first week that are contracting physiologically, they maintain normal vital signs. They're not tachycardic. Their blood pressures are normal. Looking at term babies also tells us that they're literally starving the first few days of life because nothing's coming out from maternal breast milk, but they're fine. Their heart rates are fine because they're forced to contract and pull all that fluid out of their lungs to maintain their blood volume. So we sort of, in a gentle and judicious ways, need to still allow that for premature babies to have a smoother transition from extrauterine life.